Hi, good morning, everybody. I'm very excited for our seventh episode of the Health System Fix podcast. My guest today is Dr. Pouya Afshar, his dear friend. Dr. Afshar is a physician who's board certified in internal medicine, hospice, and palliative medicine, and venous and lymphatic medicine. Prior to medicine, he received his MBA and was working for General Electric Healthcare, after which he transitioned to medical school and completed his residency training. He served as the assistant clinical professor of medicine at UC San Diego, where he practiced as a hospital-based physician. Pouya Afshar's interest was around medically complex patients, elderly patients in the skilled nursing facilities. In 2015, Dr. Afshar founded Presidium Health to provide a comprehensive model of home-based care. The goal of Presidium Health has been to provide 24/7 access to medical triage support and being able to deploy diagnostic and treatment modalities in the patient's home. This is efficient and safer and less costly than emergency room care. Dr. Afshar is also a devoted husband and father of 4 children. He's an avid soccer player, a former personal trainer, has completed 14 marathons. We met during the California Healthcare Foundation Healthcare Leadership Program, and I'm really excited to have him on today. Hi, Pouya. How are you doing?
Good morning, and thank you for having me as a guest on the podcast. Excited to talk to you.
Let's talk a little bit about your childhood, early life, till you started thinking about college and professional careers.
Absolutely. So I'm an immigrant. My parents are from Iran. And at the age of 3.5, my father left the country when it was stable at the time to get his master's degrees. Left the country. We're supposed to be here just for a few years. And while we were here in the country, the government was in turmoil. There was a new regime. And we said, let's just wait a few years before we go back. And fortunately, 50 years later, we're still here in the country. And I was fortunate enough to have the opportunity to be raised in America. And so that sort of set the stage for my childhood. And then from there, like an immigrant family, my parents pushed education. I was doing my best to be a good student. Also played a lot of sports, a big sports nut since I was very young, and continued on into high school, tried to push myself in academics and athletics, and realized at a fairly young age that I wanted to be a physician based on some of the interactions I had with our family physician. It was sort of a detour for me. I wanted to be a physician, but I had some challenges early on. I had to sort of pursue a different non-traditional pathway. And I worked for a few startups and then landed a job at GE Healthcare as part of my MBA internship. And it was fascinating because I got to sort of see how corporate medicine and the corporate world is in general operates. Again, it was great to see that, but I also learned how inefficient some of these big organizations were. And it was during that time that I also learned that I wanted to go back into medicine as well.
Once you have a drive to want to be a physician, want to be in healthcare, it is really difficult for anything else to take you away from there. For a while, when I first came to the US, I was volunteering in a research lab. And even though everybody is very nice and it was a great learning environment, I realized I really want to be seeing patients. And it reminded me very quickly that that's what I wanted to do. Moving ahead a little bit, once you finish your medical school, you finish your residency training, you start work at UCSD as an academician. What was that first experience like as a new clinician? And then what was your first leadership role there?
I started off my career going to academic medicine thinking that this is what I wanted to do. I was very enamored by just the prestige and the opportunity to work with residents and students. And I took an interesting role. During residency, I thrived working at nights. I liked it because I was able to sort of have my days to do other things. And so I took a job at UCSD as one of the first 3 nighttime hospitalists. Prior to me joining, they never had a nocturnist program. And I always tell people by working nights in the hospital, I got to see perhaps some of the most inefficient side of medicine, which is what happens when doctors turn their phones off. And that ultimately gave me the inspiration for Presidium Health. And, as far as leadership during that time, I was very motivated to be a night physician, and I was passionate about that sort of niche within the hospital medicine space. And I think the division saw my interest in that, and they asked me to become the representative for our 3-person group within the division of hospital medicine. And we grew our program and brought more nocturnists in, and I was the person who was in charge of interviewing and recruiting candidates that would perhaps want to be full-time night physicians. That was my first, I guess, entryway into the leadership space in a large academic setting.
One of the interesting pieces of healthcare leadership is before you enter leadership, all of us have these ideas and things we want to implement. And once we do enter leadership, we realize there's this whole other piece of healthcare leadership that was not obvious to us in the beginning. Like, was there some experience like that that you remember being different?
Yeah, leadership experience for me came after I left academic medicine and started a healthcare startup company. And I think one of the first um, big revelations was learning to let go of all the things that I wanted to be in control of. You know, as a type A person, I've always had my hands in everything, want to make sure I had control of everything that I was doing, and quickly realized that if I wanted to start an organization and be the leader, I had to be comfortable with letting go of those tasks and delegating responsibilities onto other people and being comfortable with the idea that I'm not going to be the expert in everything that we did in our organization. The other part of it was realizing that as a leader, I had to be a good, actually a great communicator, trying to get others motivated to share the vision and mission that I had and the direction I wanted the company to go in. And it was really important because what I was getting involved in that time, home-based care, it was sort of unorthodox. Most clinicians, healthcare workers were used to working in a brick and mortar clinic or a hospital. And I was trying to build an organization and recruit people to work in a non-traditional setting where we're out in the field providing care without a lot of the creature comforts of what we have in institutionalized healthcare. And, you know, that communication skill as a leader became even more important as I tried to raise capital and not only convince my staff, but now I'm convincing people with deep pockets to put their millions of dollars into our organization and believe in this idea that at that time had no metrics, no foundation. It was an idea that I tried to get others, especially these venture capitalists, to believe in, and again, ultimately write us a check to keep us alive.
One of the pieces you said that you have to learn how to give up control. Hopefully, firstly, you hire the right people and then give up control and let them make their own mistakes, which is also really hard to do. Like you would make mistakes also. They will make maybe slightly different mistakes. And so just allowing that is just a huge learning curve in leadership.
Absolutely. And just to sort of comment on that, I'll say it wasn't a very smooth road to get to that leadership position. I'll just tell you very openly, when I first had the idea of starting this organization, I didn't want to be the CEO. I wanted to be the chief medical officer and focus on the clinical side of things. And I hired not just one, but two CEOs before I took over the helm. And each of those transitions was really challenging and difficult, you know, trying to get someone who had invested some money in the company to leave, bring new leadership in. And again, it happened twice. So it was a good experience for me. And I learned a lot from the two former CEOs. And I think they were there at the right time. They helped us get to a position where we needed to be. But ultimately, I think the company reached a point where myself and my co-founder, we had to sort of take over the reins and guide the ship.
Right. I think once you're so passionate about a particular project, I think especially as a founder, I am not one. I realize I'm great at a number two role, like the person who gets it done, which is kind of your initial impulse was to be the CMO or COO, I think, but if you have that such a strong vision, really eventually you have to step in and drive that direction. Is that kind of what was the realization?
That's exactly it. And, you know, here's the thing I'll say about healthcare companies as a whole, and this is a bit of a generalization, but a lot of healthcare companies are run by non-clinicians, which again, I'm not going to be overly critical of that. Sometimes I think it's advantageous to have somebody or an executive team that is not just business minded, but is also clinically minded as well. And unfortunately, those of us in healthcare, particularly physicians, don't get a lot of training. In fact, we get almost no training on the business side of medicine, and we're kind of positioned in a silo to focus on clinical care. So I think stepping outside of that boundary and learning a bit about the business side of medicine allowed me to sort of broaden my horizons a bit.
And you're absolutely right. In healthcare, we do not get any business training. And at the same time, Many physicians or healthcare professionals don't invest in that leadership journey. You have put in that effort to educate yourself about the business end of the healthcare, and that really gets you to be a good administrator and a CEO. And just being a physician is not enough to be in that role.
Absolutely. Yeah. But again, I think hopefully there'll be more clinicians involved in leadership, because I think that's a unique skill set that we bring that people that aren't clinicians don't really understand as much as we do. And it also allows us to focus more heavily on the clinical side of things, perhaps put that as a number one priority and let the finances sort of hopefully fall thereafter.
Going back a little bit to the decision of leaving academic medicine, that obviously was not an easy decision. And it's especially the UC system, it's tough to leave and do something else, especially entrepreneurship. I know it was not an impulsive decision, it's cumulative over time. What few things that you saw finally which said, okay, I've had enough of this?
It was a sort of a gradual process. Let me just first say that the journey that I had was very difficult on me physically. So I was working for about 10 years of my life. I was working full-time night position in the hospital. In fact, multiple hospitals at one point. I was rounding at 3 different hospitals in San Diego County. And then when I was done with my shifts, I'd go straight into my daytime job and try to, keep the organization moving, and also at the same time trying to maintain my health and manage my 4 kids and a family. So it was difficult, certainly for the first few years, and I had to do that in order to be able to keep up with the expenses of the company. So I was working night shifts, working a lot of extra shifts to cover the expenses for the daytime sort of passion that I had. And there came a point in time where what I was doing in the hospital was certainly a good experience for me. I learned a lot about that institutionalized healthcare system, but also I was at odds with some of the things that I was doing. I realized I was sort of a puppet a bit in that system, and being forced to bring patients in sometimes that I didn't think needed to be in that healthcare setting, especially since I understood and I had experience with what goes on outside of healthcare. And once I got to a point where I felt like I had at least a little bit of a capital cushion to be able to make that leap of faith, I went from full time to 50% at the hospital. And then ultimately I cut the cord, and it was not an easy transition. I mean, if it was just myself trying to manage this, it's one thing, but I had, a wife, 4 kids, mortgage, I got to pay for health insurance now. It definitely wasn't easy, but I took a risk and gambled on myself. And so far, at least, it's paid off.
When you first started Presidium Health, what was the goal of that? What is the goal of the company? What service were you looking to provide?
Yeah, from a very high level, if you look at our healthcare system in this country, we spend over $5 trillion a year on healthcare. And it's interesting that the healthiest 50% of the population in this country only consume 3% of that healthcare budget, which is nuts. Those are the people that go to the doctor's office once a year, and that's the end of their healthcare needs. Meanwhile, on the other end of the spectrum, the top 1%, they consume up to 30% of that $5 trillion budget. And if you do a deep dive into that population, you realize that number one, that population and their expenses are heavily tied to institutionalized healthcare, i.e., the emergency department and hospitalizations. And if you look even more closely at those patients, you realize that not only are they medically complex, but they're socially complex as well. And it was that exact population that I would see in the hospital working nights, again, especially when at night physician office hours are closed. And so these patients don't have anywhere to go to, and they end up in the ER, end up getting admitted. And many times they would get sent to a skilled nursing facility and stay there for a few days or weeks. And then from there, discharged home with home health. And then I would see these patients basically cycle through the system over and over and over again. And at some point, while I was working in the skilled nursing facilities, I realized that some of these patients asked me to become their primary care physician. And I never had a brick and mortar office. And on a whim, I just started showing up at their house and started doing doctoring stuff at their house, and quickly figured out to how to get the logistics of the things that I needed, the tools that I needed, including how do I get labs in someone's house, x-rays, make sure they get medications delivered. But the most important piece for these patients was giving them access to someone they could reach out to in real time to address their concerns. And once I provided that access, I realized it was fairly easy, especially as an internist, where history is the foundation of our ability to diagnose. And because I had history with these patients and I knew who they were, know their medications, their diagnoses, when they would call me, I would be able to respond to their needs in real time. And that essentially was the inspiration for Presidium Health. And from there, once we built some experience amongst the what I call a dual eligible population, the Medicare and Medi-Cal patients, in a fee-for-service model, realized that we were making a huge impact on their lives. Not just keeping them out of the hospital, but giving them a better lifestyle that allowed them to thrive in society and not be so dependent on going to the ER and the hospital on a regular basis. And then from there, we transitioned into the value-based care world, which really sort of set the stage for the company's growth.
I think the piece of the history that you mentioned, you also had obviously a a very unique insight into their real lives, into their homes, which physicians, even if they're following them long term in a clinic, do not have that. They have the version of the history that the patient is going to tell you when they come and see you. They don't have a very true lens into what their life is like outside of the clinic walls, which is where a lot of clinicians get uncomfortable caring for people outside of the clinic walls because that's where we feel protected. We have all of our things that we need, but that may not always be the best setting, as you're saying, for the patient to receive care in.
That's right. And again, we're also making the assumption that these patients are going to their primary care doctor's offices in the first place. So the patient population that we were dealing with had a very loose connection with their PCPs. Oftentimes they had never seen them. They certainly had somebody assigned to them because the health plan has to assign a PCP to them, but the patient population that we're going after, the top 1%ers, most of them never even saw their primary. So their primary doctor was in the ED, that emergency room doctor who would see them on an ongoing basis. But yeah, there's a lot of insight that you gather when you step inside someone's house. And I think this is where, you start to see the importance of merging medical and social care, the social determinants of health, especially again, I keep focusing on the top 1%. If you don't address their social needs, the medical needs will never be solved. And by stepping into someone's house and getting a full picture of the complexities of what they're dealing with. And when I say house, sometimes that may be on the corner of, Broadway and Fourth, wherever they're sort of staying. It could be unhoused. They could be sort of in between different housing units and so forth. But yeah, I definitely get a lot more insight when you provide care wherever the patients are, as opposed to asking them to show up in your office.
It's interesting in healthcare, you go through so much training, and then the training is important, and at the same time it makes you believe that your medical diagnosis and medications you offer is the most important thing. And then you practice medicine, and especially in underserved communities, for a while. Then there's a day I remember realizing, oh yeah, I understand why people say housing is a healthcare issue. And these things start clicking that there is so much more than this antipsychotic or antihypertensive that I can prescribe to this patient that actually has a lot more impact on their life than these medications would, even though they're
That's right.
important.
That's right. That's interesting you mentioned that, because as you guys know, many of the pressures that we face as physicians is to make sure that we meet certain guidelines and metrics, make sure their A1C is below a certain amount, make sure their lipid panel looks a certain way. That's all really almost irrelevant. Maybe not irrelevant, but it's so secondary or tertiary to their basic needs. This person needs a roof over their head. They need food. They need someone to address their behavioral needs, that their mental state isn't stable. What's going to cause them to want to fix their diabetes and their hyperlipidemia? So you really have to address those hierarchy of needs first before you can tackle the nuances of adjusting their blood pressure medication or adjusting their insulin to fine tune their chronic disease states. And again, not that it's not important, it's just that it has to be placed in a perspective where other things take priority over those medical issues.
I remember talking to one of my colleagues a while back, and she's an amazing doctor, but she was very conflicted because one of her patients, who also had some psychosis, so we were managing, and she was providing HIV care. This patient needed to go into palliative care. And this person had finally gotten some housing after years of being unhoused. And if he had gone into palliative care, he would have lost the housing. And he was refusing to do that. So we were really talking about maybe we have to really consider this fact that him having a place to lay his head, which is consistent and his own, may be more important than the medication you're going to offer him. And this is such a difficult thing to accept as a physician because of the training we get. But it is a really an important thing to consider for somebody for whom that's important.
Yeah, and it goes beyond just sort of understanding the importance of it. I think from the patient's perspective, what it also does, it builds trust. So you come in as a physician and they're used to people just talking to them about their diabetes and their hypertension and everything else. When you start to ask them what is it that they need and sort of broaden that question, it really helps you build a bond with the patients. And this is really critical, especially for the patient population that we're talking about, because they really are disenfranchised. They don't trust the system. And by having a conversation that's not so healthcare focused and trying to understand what their basic needs are allows us to build a tighter relationship, one that has more trust attached to it, so that at some point, when we do get to a point where hopefully those social issues are addressed appropriately, then we can start to have conversations about, making sure they take their medications and stay compliant with their diet and their exercise and everything else that we sort of want to push as clinicians.
You think, as you said, it really helps rebuild the human connection, which is so important for healing. I think a lot of medicine now is pushed in a way that people they want to do the right thing. They're not set up to do the right thing, and this kind of helps you re-engage with the patient in a way that is more supportive, and you can see them better. You can understand their needs a lot better.
Absolutely. If I was a patient and I was unhoused or I didn't have a refrigerator to put my diabetes medications in and someone's talking about fixing my healthcare, I would basically tune out because, I would think that they don't even understand where my problems really rise. So when you start to open up those conversations, again, I keep harping on this, but trust is so important to change behavior. And unless you open up that conversation to include non-medical things, that trust is never going to be built.
So let's move along on the journey of Presidium Health. Can you talk a little bit about the impact of CalAIM on Presidium Health?
Yeah. Um, Prior to CalAIM, Presidium Health, the organization that I co-founded, we were doing CalAIM stuff. I'll just say that very generally. The intent of CalAIM, from my perspective, was to force the health plans, particularly Medicaid plans, to infuse social determinants of health into their high need, high utilizing population. And again, before CalAIM became a thing, our model of care was exactly that. Make sure that there was integration of medical care. And by medical care, we're talking about not just chronic disease management, primary care stuff, but also full-time access and acute care outside of the institutionalized setting, making sure we addressed behavioral needs in an integrated fashion, and then adding social issues and social determinants of health into that sort of trifecta. And we proved early on that that model worked. In fact, our first contract with a local Medicaid plan, we were given a list of 93 patients who in the prior year had been hospitalized 535 times. So it's an average of about 6 hospitalizations per patient per year. And these 93 individuals, as a result of these 535 hospitalizations, racked up $17.9 million of healthcare costs per year. That was sort of the benchmark that we were held against. And by deploying this, what we call concierge care without the fare, being everything and anything to these patients, medical, social, behavioral, and being available 24/7, trying our best to address everything that they possibly needed, fill out my tax return so I can qualify for government benefits. We showed that model worked. At the end of 1 year, and this is the irony, we provided more care than they've ever received. And by doing so, we reduced our hospitalizations by over 50%, and the cost of care went from 17.9 million down to 11.9 million. So we saved $6 million by smothering these patients with more care than they've ever received. That foundation really mirrored well and positioned us well in the sort of new age of CalAIM in California. And again, as I mentioned, CalAIM's intent was very clear: infuse social determinants of health into these high risk, high utilizing patients. And for us, it was an opportunity to showcase our metrics. So when we spoke to a health plan and they said, okay, great, you're interested in ECM or community supports, what experience do you have in this? And we said, well, we actually have a lot of experience. We've been doing this before this became a thing. And we showed them our metrics, and it really wowed these plans that, wow, okay, these guys seem to know what they're doing. And it allowed us to quickly build some relationships in an expedited manner and showcase what we've done. I think the only criticism I have of CalAIM, and this is, I think, how most government programs are run, they haven't tied any performance metrics necessarily to these services. It's more of a checkbox. Make sure you find vendors that can address social needs. But at least, again, it's a step in the right direction. And for us, it was a huge boost in terms of allowing us to build these relationships with health plans, bringing in revenue from that model, and hopefully forging relationships that over time, if and when CalAIM goes away, we're able to continue into the foreseeable future.
One of the problems I see with metrics in general in health centers is even though some of them are aligned with the patient's health, they're typically aligned to make sure the health center keeps getting funded. Do you think that's kind of true or not really?
Yeah, I think one of the central tenets in business is to make sure incentives are aligned all the way through, right? And so when we built our model of care, number one, we wanted to make sure that the patient was at the focus and the center of everything that we did. And, we made sure that we addressed their needs, we addressed the health plan's needs, their needs to make sure they provide great care, that they have good clinical metrics while simultaneously making sure the costs don't run up too high. As an organization, we wanted to make sure that we were addressing those needs and staying fiscally responsible, making sure we had some profit to stay afloat and continue our services. And so we were able to construct a contract that truly aligned incentives from the patient to the health plan to our organization. I would say that perhaps the only group that we may box out are the institutionalized healthcare settings that, at least before we got involved, they would certainly benefit from these patients coming into their hospital systems and driving revenue for patients that are frequent utilizers of their institutionalized healthcare.
If you were to be the person who had to design the right metrics, what should they be?
Yeah, the metrics are fairly simple. If you look at it from a high level, I think the triple aim, or if it's a quadruple aim now, is really the crux of where we all want to be in healthcare. We want to improve outcomes, clinical outcomes. We want to make sure that patients are satisfied with the care that they're receiving and they feel like they're being listened to, their needs are being met, all while reducing the total cost of care. If I were running CalAIM, I would make sure that there are some performance metrics tied around clinical outcomes, patient satisfaction, and make sure that the finances are also not spiraling out of control. It's really that simple. That sort of triple aim mentality can be applied throughout everything in healthcare. And if we sort of took that triple aim approach, I think we'd make some dramatic improvements in our healthcare system as a whole.
Working for like patients in the home or in the community space, I'm sure the first part of that intervention, maybe if you're talking about a whole year, first few months of that for a new patient is very resource intensive. Have you seen the model almost predictably get less expensive as you keep engaging a lot early on?
Absolutely. Our model is rooted on behavior change. And so you're absolutely right. The first phase, let's just call it that for lack of a better word, first phase of our program, it's very intensive with a lot of touch points. Sometimes we're talking about 20, 30 touch points per month per patient to build trust, to get them engaged. And then from there, once we have that and the behaviors start to change, then we start to scale back our services and almost put them into a maintenance program. And that is exactly the way we've modeled our program, is that they receive those high intensity services typically in the first year. And then once we've seen some behavior change, we push back a little bit and don't have to spend as much time and energy and resources on those patients because we've instilled that behavior change in their lifestyle.
But then also, I think the key pieces must be that they know reliably that they can reach you anytime, right?
Yeah, and you're absolutely right. It's the access is absolutely critical. And the other key piece to this equation is the fact that we're not an episodic model that's coming in to put out a fire. This is a longitudinal model that has to be built over time, really over the patient's life. So you're absolutely right that once we establish that trust and that foundation and we've made that behavior change, the goal is not to cut the cord and say, okay, our job is done, go take care of yourself. It's to continue to be there throughout their healthcare journey, throughout their challenges that they might face later on, so that they always have someone they can lean on, the sort of quarterback, if you will, of their life.
Yeah, traditional medicine is episodic. So we treat the urgent issue and say bye and treat the next urgent issue. And we typically are not doing a lot of preventative care or prevention, whereas now you are treating the episodic urgent issue and getting them to a place that you are the same team who will do prevention in the future. Or you're not just treating episodic.
And the other key piece of I think that it's important, and it's one of the sort of pillars of success for this model, is that it truly is an interdisciplinary team approach. The primary care piece is certainly important to develop that relationship and build a foundation for other programs that we've incorporated into our model. So from our standpoint, what's really needed are three components. We have the medical care, which again, it includes both chronic and acute management, a behavioral health component that's directly tied to the primary care piece. It's not an outside group. These are psychiatrists, psychologists, and other behavioral health team members that work directly with the primary care team, and the primary care team has instant access to whatever behavioral health needs our patients are looking for. And then the last piece is the social side. So we don't outsource that. It's our own internal team that's, again, integrated with the behavioral and the medical. And together, when these three groups are working alongside each other, it really is the recipe for success for this top 1%.
I mean, you resolve the biggest issue in healthcare, which is silos that get formed, and the team members who are supposed to care for the patient together and talk to each other. We have time to talk to each other and collaborate. That's missing in most of healthcare. So by just taking that out and making sure everybody knows you're on one team, you're working on this together, just the impact on the clinicians plus the patient obviously is huge.
And think about from the patient's perspective as well. When we interact with them, they're interacting with several members from our team. It's the primary care physician called, or the psychiatrist called, or the person handling their housing needs called, all under one roof. It really allows them to forge a very strong relationship with us, knowing that there's one organization that can address almost everything from A to Z.
At my last job at San Isidro, we built a CCBHC program, Certified Community Behavioral Health Clinic. And I'll tell you, the real difference that I feel was made is that every week we have a 1 hour treatment team meeting where every single team member is on there. It's a case manager, peer support, addiction medicine, psychiatry, occasionally PCPs, everybody is on that meeting. So anything that's complex and that's going on with that patient is discussed, decided, and everybody's on the same page. And just having that 1 hour block for clinicians just increases the kind of positive impact you have on patients.
That's exactly a key component of our model as well. We have weekly huddle sessions where everyone is on the call, and we highlight the members, the patients that are having difficulties that week, the ones that are really challenged, and we bring them into a forum where there's multiple people providing their input and their guidance and their expertise to make sure that collectively we're able to come up with a solution that truly meets the needs of the patient.
It's strange, right? It's so simple.
Yeah.
Not doing it is so short-sighted, and that's how a lot of medicine is practiced.
It's simple, but at the same time, it's complex as well. So you have to form all of these entities and bring them together. And there's no playbook for this. We never had sort of anything to sort of fall back on. We had to build it on the fly and learn what the needs were, and we built those teams around the needs of the patients. There's a sort of a tenet in business that you want to understand your customers. You want to make sure you get feedback from focus groups to understand who these people are that you're addressing. And for us, that's exactly what we did. We listened to our customers, i.e. our patients, to understand what their needs are. And then that is what led to this sort of foundation of medical, social, and behavioral that we believe handles the majority of their care needs.
And actually, you're also listening to the needs of your team because this kind of care reduces burnout and provides more satisfaction to clinical team members than that episodic siloed care.
Yep. And so that's interesting you mentioned that. So as I mentioned, the triple aim has become the quadruple aim recently, and the fourth piece of that element is clinician healthcare burnout, healthcare provider burnout. And so you're absolutely right. You can certainly do as much as you can to address the needs of the patients, make sure that their clinical needs are being met, make sure they're satisfied, make sure the costs are being driven, but at what cost? Oftentimes that cost and that burden is placed on the clinicians, the frontline clinicians. So we learned is that by allowing these clinicians to have these resources so that when they see their patients and they realize that, sure, I can talk to them about their diabetes and making sure that they're taking their insulin and so forth, but they don't have a place to put their insulin. It's not even a conversation at this point. How am I going to fix that? The satisfaction of being able to say, I have someone I can reach out to address this. So when the physician is writing an order for some labs and some medications, they're also writing an order for find housing, and that goes directly to our team. So that is absolutely a critical point to all this, is that we're preserving the sort of lifestyle and the potential burnout of our providers by giving them as many resources they can to execute their services without feeling like it's going to fall on deaf ears.
Right. How often are you seeing mental health diagnoses or substance use disorders impacting how a patient is functioning in the community?
Because we have a very biased and a very focused group of patients that we're targeting, the top 1%ers, I'd say conservatively, 80% of our patients have some element of behavioral and or substance use disorder on top of their complex chronic disease states that they're dealing with. So again, that is also why we had to make sure that that was in-house and integrated directly into the model.
Are you seeing a lot of serious mental illness also?
Probably a quarter of our patients have some SMI that we're dealing with. And again, it's being able to lean on a psych team that has resources and experience really builds success for that population. We do utilize community-based resources for them, but at least we're the ones that are driving that and making sure that those needs are being immediately met as much as we can.
Oftentimes, the psychiatric treatment in hospital setting or in the institutionalized setting is so insufficient and episodic again. I've had patients who are suicidal who go to the ER, they're released in a day. Obviously, their depression is not resolved. What they really need is hand holding between those episodes, right? Between that severe episode, which is kind of what you're trying to do.
That's exactly it. Yeah. And, as an aside, that's an issue that we're facing in the United States as a whole, is that we don't have enough inpatient beds to be able to house all these individuals that need a lot of intensive care. And so if we don't have that institutionalized healthcare resource, we have to find other ways to compensate and provide care for these patients that really need, again, not just psych support, but they need other types of support to make sure that they're appropriately taken care of after they've been discharged from the emergency department.
So obviously the case managers you have must be elite. Are you doing a specific training for them, or how are you getting them ready?
Yeah, we have different types of training they go through in-house, making sure it's patient-centric, they understand the impact of trauma on their development, motivational interviewing skills. That is absolutely a key component of our model. And also, our team is very resilient. And by that, I mean, with these patients, your first pass, second pass, third pass oftentimes is not going to be successful. And we've learned to understand that don't let that bring you down. Continue to be persistent and continue to offer support. Another piece of it is making sure we meet the patients where they're physically and mentally at. So, that patient of ours, for example, that has substance use disorder, and they may not be ready to let go of that addiction that they have at this time. We don't turn our backs on them. We continue to be persistent, continue to reach out. And the goal is that at some point, eventually, through trust and persistence, that they'll start to change that behavior.
Do you have any advice for people thinking about entering healthcare?
Particularly, I'm going to focus on people choosing a career in medicine and wanting to become a physician. It doesn't have the same sort of look and feel it had 40, 50 years ago. Hopefully, people that are entering healthcare, number one, are doing it for the right reasons, that they truly have an intent and a desire to want to help people, learning that you have to sacrifice a lot to get to this stage, many years of schooling to get there. And at the end of the day, the one piece I think that would hopefully allow people in healthcare to be successful and happy is to find a niche that they're passionate about and to not be afraid of stepping outside of the silos that we're oftentimes forced to go into. Again, on a personal level, I'm an internist. And when I came out of medical school, I had an opportunity to choose different pathways. I chose internal medicine. And once I chose internal medicine, once I graduated, I was sort of given options. Do I want to work in a clinic and see 20, 30 patients a day? Do I work in a hospital and do 7 shifts on, 7 shifts off, work in urgent care setting? And those are my options. And so I chose to take a path where I dabbled in multiple arenas. That gave me satisfaction and it broadened my horizons and gave me inspiration for something that I never would have even imagined would be a possibility had I stayed in the hospital and just done hospital medicine or worked in a clinic and just did, outpatient medicine. So I think going into healthcare, new students that are going in, just make sure you keep a very open perspective, step outside of those silos, maybe pick up a class or two on the business side of medicine, which will also empower you. And by doing all that, I think it'll give you more options, make it more exciting, and hopefully lead to some leadership opportunities.
You're absolutely right, because I think a lot of times the burnout happens because the way you imagined practicing medicine, you're not necessarily getting to do it that way. But the fact is that as a physician, you also have a lot of power. It is not easy, but you have a lot of power to try to design the kind of work you really want to do. That'll help you feel better, and help you feel good about the work you're doing and the impact you're having.
Absolutely. Yeah. And again, variety is the spice of life. So the more you can do, the more you can learn. That variety becomes a key component of not getting burnt out.
I was going to ask about advice for people who are physicians who are thinking about a leadership role.
Yeah, it's interesting. When I was an attending at the academic hospital, I had several students, residents, for example, in their first year, or even some medical students that they came in and they wanted to leave medicine right away and become a consultant for, um, you know, whatever, Kinsey or some group as a healthcare consultant. I think the first bit of advice is become a master of what you've been trained in first. Build that foundation and understand your profession inside and out. Once you've built that foundation and you have credibility in whatever you've done, that becomes sort of the launching point for other opportunities ahead. And then from there, I think, as a healthcare leader, and this is maybe more focused on entrepreneurship, keep your eyes open for inefficiencies in what you see. It's those inefficiencies that lead to leadership opportunities, entrepreneurship opportunities, and hopefully, as you're looking at those inefficiencies, you're also doing it with making sure that you're addressing your own personal passion as well. So, if you find something that you believe in and that you see that there's an inefficiency in the system, there's so many opportunities, especially for clinicians that are on the front line and have firsthand experience with what those challenges are, for those individuals to take on leadership roles that will ultimately change and drive change for a lot of the things that are so broken in our healthcare system. And I hope and pray that, in the next 10, 20 years, we see more and more clinicians stepping into healthcare leadership roles as opposed to people that are just, and again, I'm not going to be overly critical of the business people. I guess I'm a business person myself with an MBA, but hopefully there's more of us clinicians stepping into those leadership roles and giving some of our guidance as a clinician and somebody who has business experience as well together to drive change.
By the way, that's great advice. One of the barriers I was seeing when I first did not have my MBA, wanted to have more impact on administration and how things are actually running or shaping the system. There was a lot of resistance to having physicians give that kind of input in how the system run. The MBA helped me convince people that I'm actually interested, but also it gave me a much broader view of the system.
I tell people the MBA is a very general degree, and I'll just sort of pick on that degree itself. It's certainly a great thing to have and certainly builds credibility. But what I learned in business school, first of all, the world of business is so diverse, from finance to marketing to operations to, strategy. I learned enough about business to know that I don't know that much about business. And just coming in with that lens at least gives me some insight about what I'm up against and making sure that I hire the right people that know perhaps they're better at finance or they're better at operations. And I don't have to be all that, but just understanding how it sort of all fits in allows you to become a better leader and delegate these responsibilities to the respective experts in their field.
Delegate once you know something. At
Right.
least you can pick out the red flags.
That's right.
Like, coming to the last question, what is the most exciting or challenging project at Presidium Health you're working on?
Yeah. Our goal is to provide a service that impacts the top 1% of our nation's most medically, socially, behaviorally challenged patients. And even with the metrics that we have on hand, I can just say thus far we've saved over $20 million in annual expenses on a population of just over 500 patients. You would think that that would immediately open up all these doors to health plans saying, "Oh my gosh, can you please come in and help us with our population?" The one challenge I've sort of come to the realization is that what we're doing is very unorthodox and it requires change. It's not the traditional contracting pathway that most health plans are used to dealing with. We're asking to take on risks and share in the savings that we're able to bring to their health plan. That is, at least for now, while we're in that sort of pioneering transitional stage where we're trying to get these health plans to be more open-minded about value-based care. And let me just say as an aside, the word value-based care is certainly a hot topic these days, and everyone's sort of trying to build models of care around it. But what I've learned quickly is that it hasn't been implemented and it hasn't become as mainstream as it should be. And we're caught in those early stages where we have to educate and get the health plans to be more open-minded about what we do so they can give us an opportunity. But despite having these great metrics in our hand, it doesn't just automatically lend itself to immediate expansion and scale. There's still a lot of bumps in the road for us, but I'm going to stay optimistic that as pioneers, we have to just understand that this is the road that we're in, and these are the roadblocks that we're going to face. And as long as we stay true to our mission, and hopefully other participants get involved, and there's more and more people doing what we're doing, it'll become more mainstream to the point where one day we can positively impact a healthcare system that many have critiqued as very broken in the United States.
Oh yeah, it's been a pleasure talking to you. I really enjoyed learning about your journey, and I have full confidence that all the roadblocks ahead have no chance because you are going at them. Just at least for the last few years, I've seen your journey and your passion on for working on this. This is a much needed service.
I wish you the best as well with your podcast. It's been fun talking to you, and hopefully we'll stay in touch and I can provide some updates in the future.
Sounds good. Thanks so much, Pouya.
Bye.